In this video, we are going to talk simply about heparin, its history, how it was discovered, and what are the uses in medical science, and some contraindications or adverse side effects of this medicine called heparin. Heparin, also called as unfractionated heparin or UFAs, is a medication naturally occurring naturally occurring glycosaminoglycan. Heparin is a blood anticoagulant that increases the activity of antithrombin. It is used in the treatment of heart attacks and unstable angina. It can be given intravenously or by injection under the skin. Its anticoagulant properties make it useful to prevent blood clotting in blood specimen test tubes and kidney dialysis machines. Common side effects include bleeding, pain at the injection site, and low platelets. Serious side effects include heparin-induced thrombocytopenia. Greater care is needed in those with poor kidney function. Heparin is contraindicated for suspected cases of vaccinated-induced pro-thrombotic immune thrombocytopenia or VIPIT, secondary to SARS-CoV-2 vaccination, as heparin may further increase the risk of bleeding in an anti-PF4 or heparin complex autoimmune manner, in favor of alternative anticoagulant medications such as argabatroban or danaparoid. Heparin appears to be relatively safe for use during pregnancy and breastfeeding. Heparin is produced by basophils and mast cells in all mammals. The discovery of heparin was announced in 1916. It is on the World Health Organization's list of essential medicines. A fractionated version of heparin known as low molecular weight heparin is also available. Now let's know or talk about the history of heparin. Heparin was discovered by J. MacLean and William Henry Howell in 1916, although it did not enter clinical trials until 1935. It was originally isolated from dog liver cells. Hence its name hepar is Greek for liver, and so the word is made hepar plus in, heparin. MacLean was a second-year medical student at Johns Hopkins University and was working under the guidance of Howell investigating pro-coagulant preparations when he isolated a fat-soluble phosphatide anticoagulant in canine liver tissue or dog liver tissue. In 1918, Howell coined the term heparin for this type of fat-soluble anticoagulant. In the early 1920s, Howell isolated a water-soluble polysaccharide anticoagulant, which he also termed heparin, although it was different from the previously discovered phosphatide preparations. MacLean's work as a surgeon probably changed the focus of the Howell group to look for anticoagulants, which eventually led to the polysaccharide discovery. It had at first been accepted that it was Howell who discovered heparin. However, in the 1940s, J. MacLean became unhappy that he had not received appropriate recognition for what he saw as his own discovery. Though relatively discreet about his claim and not wanting to upset his former chief, he gave lectures and wrote letters claiming that the discovery was his. This gradually became accepted as fact, and indeed after his death in 1959. His obituary credited him as being the true discoverer of heparin. This was elegantly restated in 1963 in a plaque unveiled in Johns Hopkins to commemorate the major contribution of MacLean to the discovery of heparin in 1916. in collaboration with Professor William Henry Howell. In the 1930s, similar researchers were investigating heparin. Eric Zorps and Karolinska Institute published his research on the structure of heparin in 1935, which made it possible for the Swedish company Vitrum AB to launch the first heparin product for intravenous use in 1936. Between 1933 and 1936, Connaught Medical Research Laboratories, then a part of the University of Toronto, perfected a technique for producing safe, non-toxic heparin that could be administered to patients in a saline solution. The first human trials of heparin began in May 1935, and by 1937, it was clear that Connaught's heparin was safe, easily available as a blood anticoagulant. Prior to 1930, heparin was available in small amounts, was extremely expensive and toxic, and as a consequence of no medical value. Heparin production came from cattle tissue, which was a byproduct of the meat industry, especially in North America. With the rapid spread of BSE, more and more manufacturers abandoned this source of supply. As a result, global heparin production became increasingly concentrated in China, where the substance was now procured from the expanding industry of breeding and slaughtering the hog. The dependence of medical care on the meat industry assumed threatening proportions in the wake of the COVID-19 pandemic. In 2020, several studies demonstrated the efficacy of heparin in mitigating severe disease progression as its anticoagulant effect was decreased. As its anticoagulant effect counteracted the formation of immunothrombosis. However, the availability of heparin on the world market, because concurrently a renewed swine flu epidemic had reduced significant portions of the Chinese hog population, the situation was further exacerbated by the fact that mass slaughterhouses around the world became corona hotspots themselves and were forced to close temporarily. In less affluent countries, the resulting heparin shortage also led to worsened healthcare beyond the treatment of COVID, for example, through the cancellation of cardiac surgeries. Now let's talk something about the medical uses of heparin. Heparin acts as an anticoagulant, preventing the formation of clots and extension of existing clots within the blood. While heparin itself does not break down clots that have already formed, unlike tissue plasminogen activator, it allows the body's natural clot lysis mechanisms to work normally to break down clots that have formed. Heparin is generally used for anticoagulation for the following conditions: acute coronary syndrome, as for example NSTMI, arterial fibrillation, deep vein thrombosis, and pulmonary embolism, both prevention and treatment. Other thrombotic states and conditions: cardiopulmonary bypass for heart surgery, e-sealing central or peripheral venous catheters. Heparin and its low molecular weight derivatives, enoxaparin, dalteparin, tinjaparin, are effective in preventing deep vein thrombosis and pulmonary emboli in people at risk, but no evidence